residential rates. So we'll just go ahead and put that on there right now. Could I have a motion to approve the agenda?
So moved.
Support.
All in favor, say aye.
Aye.
Opposed, no. So that is approved. Moving on to our consent items. We need a motion to approve the consent of the following item, the minutes for the November 17, 2025 CMHOC Finance Committee.
So, I'll make that motion.
I'll support it.
Right, all in favor, say aye.
Aye.
Opposed, no. And that is approved. So next up, we have a presentation, which is an update related to the IBH authorization, financial reports, and the CCBHC monitoring with Dr. Darren Lubbers, Brittany Bradeweg, and Jamie Davis.
Yeah, and I'll provide some context to this. And even though Lubbers is pronounced Lubbers on the west side of the state, for Darren, it's Dr. Lubbers.
All right.
This is something he goes through a lot. And the last person that did that punched him in the eye.
Yeah.
So one of the things that you are aware of is based on our 2025 closing budget deficit and things that we've been working on are the different types of reports that we need to put in place to properly manage and predict expenditures. One of those items is our ability to look at what's been authorized and the expenses associated with them versus what's actually utilized and what's actually spent. That is what we're calling the authorization financial reports. I asked IBH, Dr. Lubbers, and Jamie and Brittany, who are here, by the way, to give an update on kind of our initial stab at doing this, and then I have further updates, how we've taken their existing work and how we're moving forward. So there are two general kind of buckets, so to speak, authorizations in general, and then to help us with CCBHC monitoring, we did an initial analysis on how we're managing our CCBHC financial risk, and some recommendation by IBH to help clean that up and strengthen it, which I am proud to report that the COO and the leadership at CMH have already taken some of their recommendations, and we're already moving down the road to maximize amount of revenue that we can and get clear on how we're allocating expenditures. These were two components at risk that I told the full board, last board, that I'm moving on as quick as we can. Understanding expense related to authorizations, Medicaid as a whole, right? And then CCBHC oversight. So today is a quick update on some initiatives to be educated on what we've been doing. And then later on, you're going to see I'm introducing a new category for this committee called Community-Based Services Oversight that we'll be looking at every finance committee. So you see that. Not that the other funding sources aren't important, they'll be looked at, but I want to make sure that we got a handle and everybody's educated in how we're dealing with this. So with this, I'll start with Jamie first on our kind of approach, the model we're using to track authorizations. This will feel like you're in the weeds. So what I want you to pay attention to is the structure and the model, and not necessarily the content that you see in the different cells. Or Bob Davis is going to ask questions for 45 minutes going, what does that really mean? Okay, so it's really looking at the structure, and now we're implementing. You asked away. I'm just respecting that any logical person looking, I go, so what? So are we also going to track? It's the model we're looking at.
It's okay.
All right. Okay, here we go. And Dr. Lubbers, you can also pipe in since you're the leader of the band at any point.
Thank you.
Do you want to make any introductory comments, Doc, related to what we're doing with this stuff? And then we'll let Jamie and Brittany take over.
Well, I think we'll have better questions and dialogue once they present the material, but everything you said was, right on the money. And I just think this is like extremely important work to be able to truly understand, authorizations and, just where we're at and
Hold on one
eventually be
second,
able.
Doc.
Am I breaking up?
We got it. Yeah, we had the past comments blended with the present and anticipating the future. That seems to be working now.
Yeah.
Go ahead, start over, Doc.
Playing in the background. Sorry about that.
Well, I mean, everything you said was absolutely perfect in terms of, what this report is. And I would just double down on what you're saying, like, focus on, the intent and the structure of this. And that, I think this is going to really be able to help move us forward in terms of, being able to do, effective cost modeling and to be able to look at where we're at prospectively as opposed to just looking, in the past. But to do the, kind of forecasting models, you have to have a really good handle on exactly the kind of stuff we're going to examine today. And what Brittany's going to also show in a minute, I think, is super critical because CCBHC is, really based on, being able to have incentive payments and things that are just very important for us to be able to obtain. So, being able to understand this data and be able to use it in a very, kind of proactive, staff-friendly way, I think is what we're trying to work towards together collectively. So we're really excited about this. And I guess the only other thing I'll add before we jump in is there's so much more to do with this. And Dr. Bashirs has kind of prompted us to work with this kind of data across a multitude of different populations and programs, which we're in the midst of. So we're just going to give you like a glimpse of some of the really important work, knowing that more to come.
Thanks, Doc. So Jamie, why don't you go ahead and,
Okay.
is that the one we're at?
Yeah.
Maybe an overview and then some elements.
Yeah, perfect. So we're looking at authorization. We can pull that data out of the EMR. So just to showcase the framework, we just looked at CLS, the 15-minute unit code. We do think it's important to look at the authorizations by the service just because they're all so different. You can't really apply one framework to it. So what we do is we pull the data for a given period. Here we looked at FY25 and a little bit of 26. It's really important for us, I think, to look at the authorizations in two ways. So first, anything that's currently active is the data that we pull, right? So it's got, whether they'll be active for 2 more months or a month or not, but then also kind of look back at anything that was active during our time period, but is ended. So we'll see that down the road. So that's kind of how we actually broke this up. Monitoring those that are currently active and then reviewing those that have expired. So you can scroll down. So from the monitoring standpoint, the idea behind this one, to the next page, sorry, just gonna give good direction there. So this is important because it can help us detect imbalances. So units are authorized and we can either look to see if the units are being underutilized or overutilized, or if they're kind of being utilized as we expected. So one of the things that we've started to do, if you can kind of scroll down a little bit, that table's a little small, but we end up looking at the time period of authorization. So sometimes it's 6 months, sometimes it's a year. And we see how far along we are in the authorization and compare the percentage of units that have been used. So the example here would be on that top row, my eyes are good enough. I think the gray column is time lapse. So the person's about 30% through their authorization period, and they've used about 25% of their units.
So AC and AD.
And so what we have done, and we've updated this a little bit since this report was put together, is we're using an 8% threshold. That's 4 weeks out of 52, 1 month out of the year. Billing's a little bit lagged. So if there's an 8% difference, we're saying they're right on track. The second they either go above or beyond that, we kind of flag it. Are they underutilizing or overutilizing? And if they are, we can look at it. So, if they're underutilizing, there's like barriers to accessing services? Are they not engaged? Is something else going on? And if they're overutilizing, we also want to look, why are they using units faster than we expected them to?
Yeah, let me add a couple of
Yes.
things here. This is vitally important. And again, we're not talking about stuff that's fixed daily. Like it'd be hard to underutilize residential unless they were in the hospital, right? Which is a variable that residential providers have to deal with because they don't get compensated for those days. So we'll track it. But this is really looking at it in a different perspective. What's crucial here is the role of medical necessity and how units are utilized. So if somebody is utilizing only 10% of their authorization after, say, a quarter, we need to make a determination of the organization. Do they still need that same level of care? Because we have booked, they could use 100% of that. If they're only using 10, do we need to make an adjustment on the amount, scope, and duration of the services? And the opposite is true. If someone uses 50% of their authorization, say for a quarter or even a year, and it's way too early, was there a change in their condition and we need to authorize more units? What's been happening now in our financials, we only know this on what's paid out. So this discussion doesn't happen besides Nick sometimes getting a call of authorizing more units financially in the system because somebody's out. But we haven't studied it this way. And so it's also a question of what's being utilized and projecting what do they need and making adjustments based on that. That I think I did pretty good at some of that. Continue. Anything else you'd like to, you have any questions, what you're seeing here, board members, on this table, like what the categories mean?
I do have a question. Forgive me if this is getting down into the weeds, but the first person there, who determines what their authorization is? And does it make any difference? They're authorized 50 units, but it doesn't make any difference in terms of income to CCBHC. If they never use any of those units, we don't bill Lansing and get reimbursed for it because it's a fee for service.
Yeah.
Right?
And this wouldn't look at CCBHC expenditures. That's the next one. This is more your traditional codes we're using for Medicaid. It may be CCBH, eligible, but who determines it? The person-centered planning process.
Okay, so this is straight Medicaid.
Yeah, and the utilization management process of
Mhm.
based on your need, here's what we usually authorize. And we're still trying to answer that question. What do we usually authorize? It's based on the individual needs of the person and some other safeguards. But this is really like the amount authorized then gets into percent used in lapse time. I don't think we have a column in this particular chart because we're not looking at like what was the amount authorized, because that's like number of units. These are the percentages.
Yeah.
But this is person-centered planning, determining the amount, scope, and duration, giving you authorized units, and then it picks up from there. What's been used in what part of time and what's the difference? And then over or underutilized at that point. So CCBHC you'll get in a moment. Like that, your point is exactly right. What does it matter if the expenses were tied directly to the revenue?
Yeah.
And I wish that was the case, but it isn't. And so you have to manage it a little differently, even though it doesn't make sense that it doesn't do that.
But this is a good forecasting tool on the Medicaid side.
Yep.
Because ostensibly, if everybody uses 100% of what's authorized, that's what we're building our budget upon to live within the allowable Medicaid
In the
funds.
future. Right now, we've been building our budget on what's been spent. God help us if everybody uses 100% of their authorization. However, we need to know how accurate we get at determining that, so it isn't God help us. We should be able to get closer and closer to medical necessity, saying they'll meet 100% of their authorization, or something's off. There was a change in the client or change in the provider network, not enough providers. See, I get just as concerned under underutilization as I do for overutilization, because the reason why is vastly important.
Yeah.
This gives us a tool to start honing in this is just one code. And it took Jamie, well, didn't take her long because she's a genius, but it takes a lot of work to imagine we have hundreds of codes we got to do this for. And we'll start putting them together.
So we can put on, like, moving forward, we've also summarized it to help individuals kind of look at the code. So how many people are under utilizing, for example, this one I reran it after I sent this to you, and about 75% are underutilizing what was
Oh, boy.
authorized. Compared to a quarter or right online, rarely anybody's overutilizing this code. So,
And can you remind the board which code, I mean, I said I wouldn't, but which code is this?
community living support. the
In a
15
non-residential setting. And so imagine if our expense forecasting included 100% of the costs authorized. Our financials will look dramatically different coming in here. And it would show that we are so upside down compared to revenue that we either find a way to align that or start projecting how much people are not going to utilize and make adjustments quarterly.
So we're operating an airline here where we're overbooking,
Yes,
hoping people don't show up.
that's right. And hopefully you have enough fuel not to crash. That would be Medicaid revenue, the fuel, right? But that's exactly right. But we haven't been tracking it this way ever. And so I think it's time we do it this way. Because the region says stay within your budget. I'm like, are you saying stay with what was legitimately authorized? Or just the fuel in the tank? Because the fuel in the tank, the Medicaid revenue may never correspond to the actual medically necessary approved need. So we better hope that we're at 25%. And if we're at 25% on some of these codes, what are we doing? Why would we ever say they needed 75% more of that? So something is off with the relationship between medical necessity, calculating expenditures, and Medicaid revenue. And so we have to get to the bottom of it. Now, if we were Medicaid rich, people ignore this. Like, oh yeah, just as long as it all at the end, we'll just waterfall everything and it'll be fine. That isn't now. More you'd like to see.
We can keep going.
Yeah. Okay. So you had you have to scroll down, yeah.
Yeah, we kind of went through those. There's
Yeah.
more of the recommendations on the
And we'll
next.
send you a copy of this to them.
So this one was them looking at the authorizations that have ended. We did meet with Dr. Bashir's leadership team. We have made some adjustments. So this is 90-day window. We're kind of looking at 60 days. People are able to give really good input. So this is more of just that framework. But the idea here was to kind of just look at like exposure to risk, right? So the authorization is ended, but we still have these available units, things that people haven't used. And if somebody decides to bill for those, because we're only looking at contracted services, how much are we on the hook for? So if we keep scrolling, we broke this out by authorizations that have expired in 90 days or less, and then over 90 days. We have made some adjustments. We're going to look at it within 60 days. And so the idea behind this was that if they haven't billed, within 90 days, maybe they're not going to, right? So that's kind of that yes column, and you can see there's almost about 900,000 in there. That is maybe something that we should kind of look into and understand why there's still some units available. And can we either like close those out or do something else with that? Just because right now it's just exposure. It's risk out there. They've been authorized, these units. We don't know if they used them or not. And then the ones that are like kind of that 90 days, that no group, that's stuff that I would say like you can maybe expect to be billed for, right? So some of the providers maybe lag in their billing, this or that. That's why we kind of changed it to 60 days based on conversations. That's more realistic for when people are going to bill.
Yeah, one of the confounding factors or variables, I should say, related to this part of it is that we have 158 families in self-directed care. This is a major code in that, CLS. The technical advisory from the state of Michigan related to self-directed care says you can have an authorization that's set annually. And as long as you use all your units by the end of the year, you're good. Well, how in the heck do you do utilization management on that using a 90-day model for this code? If people are allowed to use less or more of what's been allocated, as long as the total equates at the end of the year, it means you get the November surprise. Either they overutilize, that's what we call it nowadays, right? The November surprise, or they underutilize. And so I've already had a meeting with the region, with the state of Michigan, okay, Mrs. Morningstar at the state, to talk about this issue of the self-directed care model allowing for annual authorizations. It makes tracking and predicting utilization almost impossible. And it says they could shift it around. We're not allowed to do that in any other kind of program where you're allowed to independently shift around the number of units you use per week. And so this report's actually helping, once we pull out the self-directed care folks for that code, how much money are in the that's in the mix here that we don't know, should we book as an expenditure or not? And so they're supposed to file monthly reports to us saying, here's what's utilized, but as long as they can say, and it doesn't matter, as long as I use it by the end, I can't manage it. Right? So you look at some of the dollar amounts associated here. Could you explain the dollar amount stuff on here?
Yeah. So what we did, because not all of the authorizations have a unit cost attached to them. So we looked at the claims that were billed for this specific code from the beginning of June and just took the median number and then multiplied the available units by the 610, and that's how we ended up getting the dollar amount. There are some, we ran the report actually today, the authorizations do have a rate tied. So we've been able to update this and get it to be a little bit more accurate. It's a big range. So I think that that's why it's going to be really important. I know you've already talked about the fact that you're doing that and asking people, because I think the range is between like $3 and $90. So if I'm using $6, it's going to look a little different. So we'll
Per
be able to
unit,
get
these
a
are
better
15-minute units. Just
picture at authorized, but even costs. So we can actually end up tying all this. We've worked to pull the paid claims in too. So for those the dashes are, we'll actually be able to have numbers. And then also look at it at an individual level. That was the next piece. If they authorize per week, we can actually pull the claims data and see how often they're using it. If they're authorized 64 units a week, are they consistently using it? Or is there some variability, just to help people kind of understand where to start when you look? Because there's always a lot going on and every situation is unique. So if we can at least help them start, where to look at this, hopefully, it'll do.
Yeah, and Anna, the CEO, is already working with the other directors, gathering information for each of the other divisions. Let's pick a couple of services, one or two, and try this as a model and see if it's utility. Because eventually you're going to need total authorizations by all codes to get a handle on this. But there's some lower hanging fruit. CLS, right, as being one of the major ones. Outpatient therapy units, we can look at those. Things like that. So we're going to have each division look at one or two codes and apply the model to see if it's utility. But you can see we're trying to get closer. What's out there? What does it cost? And what are we actually utilizing to ask the question, do they still need it? Now, none of that, Myra, you can tell me if I'm wrong, or Nick on this, is right now part of where we are at with expenditures. So where we're at with expenditures is what's been paid. So you can see we're at the end of the journey all the time in our financial reporting, and you're only getting the result of all of the questions and work you have here without us looking at the steps. It's just like, oh, they did a service. This is for primarily out our contracts only at this point, right? They did a service, they submitted a bill. Was it authorized? Yes, pay it. So we have to up our sophistication in understanding that, so that we have a better mechanism to say, can we curb some of the paying out if it truly isn't needed? Or Holy Toledo, we haven't seen these bills show up all year. Are we going to get a November surprise on H2015 from CLS providers trying to get all their stuff in for self-directed care, which happened last year or two stipend year?
ADLs would be something that you probably would not carry forward if it was not used. But respite, you might.
Correct.
You might not use respite this month or the next month. You might bank it and use it.
We want the planful use of respite and not the random selection of when you use it. Now, some of that, like respite, is used to fill in an emergency or something, fine. But I'm talking like what we don't want is, which happens now. Oh, by the way, we forgot that we'd like to have an extra 2 weeks of respite near the end of the year because we're going to Arizona and we didn't tell anybody. Well, no one knew that. And if they're out of units, what do? Say no. We're not good at saying no yet. We're good at saying, let's check, and most likely yes. And some of that is when we've said no, we've lost appeals at the regional state level. We are afraid to say no. We need the parameters to be able to say, let's work with you. Because the way I view it, it's everybody in this county's Medicaid, not individuals, just to make independent decision. It is for all of the beneficiaries. So There are some services like respite. Yeah, you bet. We want flexibility, but sometimes, not all the time, but sometimes we get, oh, we forgot to tell you, they're in a self-directed care arrangement. The family's stuck and we're like, what do we do? We say no, they come here. No, they appeal. So we have to have the tools to demonstrate when it's appropriate for us to say no or yes, and how we're monitoring it through the year. It's not as tight as we want it at the moment. But you are right, some things you can't carry over in individual budgets, but it's all how the ranges are just the frequency of the authorization. If it's weekly units, monthly units, quarterly units, yearly. If they're yearly, this becomes stupid to look at. Well, we'll wait and see. Looks like they're on track to use half of them. Then the last month they go. And, you know, that's kind of how we're looking at it. I don't think I totally danced around your question. Did I answer it?
No.
Okay.
Does our system highlight when someone has overutilized? Does auto highlight?
Kind of.
someone's over? Do you get like? this
We don't
person
get red alert,
overutilized?
red alert.
You don't? Okay.
We're getting there.
Okay.
We got member of loss, we get danger will, okay, and then we got to figure out what's going on. But there isn't like unless I'm wrong, anyone on my team can tell me, something that jumps out like danger report.
Okay. And the same goes for underutilization.
Correct. And this is what we're trying to create with this, is a mechanism to do some of that.
Okay.
Because right now it's like, we find out when they're out of something.
Mhm.
We never find out if they didn't utilize enough of something. We find out when they're out of something by people asking for more of the something. And I'm like, well, why did we go over what we originally authorized? Well, they just did. Well, we need to catch that to determine is there a change in their medical condition?
Mhm.
Because if not, we have to say, no, sorry. Now, how to say no if it's like therapy? Well, that just means that somebody was using too much of it and we didn't catch it. They were going twice a week instead of once a week or 3 times a week. And there may be legitimate reasons they had a crisis. And then we can say, oh, I can see that. And so then we would increase the authorizations, but based on a change of medical condition, not just by accident. And, you know, so that's what we have to kind of gear up on.
So in a crisis situation where someone needs hospitalization, you would just authorize that and
Yeah.
it would then become a new authorization.
Yeah.
If they're authorized counseling and they don't show up, that would be underutilization.
That's
But
right.
that should also be a red flag.
It should be,
Where are they?
especially if they end up in the hospital.
Yeah.
They didn't
Right.
go to 10 therapy appointments. Oh yeah, Dr. Luber's had a famous report on this many, many years ago when I asked him, hey, good news, it's cheaper for outpatient providers to provide it. Bad news, no one shows up.
Right.
Do you remember that report, Doc? And so the
Yeah.
effect of underutilization is just as dramatic and problematic than overutilization, because underutilization of one service could lead to more expensive services over here.
Increases.
Right. And so we have to get our handle on what's happening and get good at least quarterly understanding what's happening to make bolder predictions of what it's going to look like at the end, both on service utilization and expenditures. Because right now there's not a convergence of that thinking. There's just expenditures go up or they go down or up. And that could be purely based on when people submit claims or other variables that have nothing to do of what's medically necessary.
And I really appreciate you bringing that up because I agree with you. I think underutilization is of equal concern. I remember some years back, we were doing an analysis of the regional substance use outpatient world. And I remember everybody was really thrilled with the budget. And I was the guy who brought up, well, yeah, but we only have the median number of one session being attended. So I don't know how that could be clinically successful if people aren't engaging, because we know for substance use treatment, more tends to be better. And so there was just a underutilization at that point in time anyway. So it was a matter of figuring out what we needed to do to retain, engagement in a more profound, efficacious manner to have better treatment outcomes. And one, in my opinion, was was a concern, and it was a clear underutilization problem that we had going at that point in time.
Mhm. Other things you'd like to share about this report?
No, just the last page was just some recommendations that we've kind of already gone over.
Great.
So.
So now I'd like to switch gears to CCBHC. And we've already taken some of your work, my friend, and did another analysis with fiscal services and our clinical team, which I think you'll be happy about. And we have figured out some information, especially on the number of people enrolled. And so what we wanted to do is to monitor CCBHC encounters and to remind the board and the public, these are eligible services for, we'll call it a CCBHC policy. Someone can be enrolled in it. It's a benefit, okay? It has tentacles into the whole operations of CMH. So there isn't a CCBHC clinic that you could walk into like I tried to do and say, where is it? It's part of the whole delivery services, and certain codes, diagnoses make you eligible for the extra rate on top of the Medicaid, the PPS1 rate. It's a personalized rate. The purpose of that rate is to cover your expenditures for those services, especially if you expand to moderate populations. So we needed a series of monitoring tools. Some of it we already started before IBH got involved. Our QI department, Olivia Martin, Tony's department, under Anna's leadership, we're already looking at dashboards to look at how many authorizations we need per team to meet our goals. But this was an initial assessment I asked IBH to do, and I'll let Brittany go through it.
Perfect, thank you. So we have experience evaluating CCBHC programs. We're focused on your CCBHC revenue, so fee for service, switching gears from managing the Medicaid dollars. And so we jumped into analyzing this data. We've looked into it a couple times. So the baseline is from November 19th. We've looked at the data also on December 1st, as well as even today, re-raising the numbers to peek in. And so with this, we are reviewing your internal and external services data. So as a CCBHC, the service needs to be provided by you or your DCO. So we have so now because you have DCOs in place, we are looking at some of the services that come.
And the DCOs are just our contract providers to do CCBHC
Correct.
for us.
Correct. Yes. So we looked at fiscal year 25 data. The reason being why we focused on this fiscal year is that it is closeout time. So the end of this month, we have to have all of our encounters submitted and cleaned up. And so that's why that is our focus. We have started to look into even this current fiscal year, and there are opportunities to monitor this moving forward. So like Dr. Brashear has mentioned, there are certain service codes or services that are provided that are defined as CCBHC eligible. There are 100 different CPT codes that go across 8 categories. So things like crisis services, it's going to be the crisis screening or any crisis intervention. We have assessments, screenings, diagnoses. So when they're coming in, they're asking for services. You do a psychosocial assessment if they're mental health. You're doing an ASAM continuum if they're SUD. It includes things like psychiatric evaluations and even brief screenings for service eligibility. It also includes things like treatment planning on both the mental health and SUD side, outpatient mental health and SUD services. So things like individual therapy, group therapy, medication reviews. It also includes things like home-based services and ACT. Also primary care services. So if they're meeting with your nurses and having screenings and follow-up services, that's also included as a CCBHC eligible service. Targeted case management, psychiatric rehabilitation like supported employment, job coaching, housing assistance. All of these are CCBHC eligible services. In the last area, peer and family support, as well as recovery coaching. So pretty much anything that you're providing to your adults and children with mental illnesses or substance use disorders. So it does look at all of those diagnoses as inclusion. It excludes IDD and autism services, but if they have a co-occurring mental health or SUD, they could be eligible as a CCBHC individual as well. So talking about the services that make you eligible as well as the diagnosis that makes you eligible. So we really lean on the Michigan Demonstration Handbook. In their Appendix A and Appendix B, it defines what these services are and what makes them eligible. So I just want to start before we jump into some of our recommendations that we don't claim to be an expert on the billing side of things, but as a CCBHC program evaluator, we get in, we work with your data. We have some insights as to kind of what's happening in other CCBHCs as well. So there have been times when we're looking at your data like, this stands out as being different, or this is not what I expected. We have DCOs in place since I think March and April. And
Right.
so why am I not seeing services yet, or the T1040 that's generated? So that is the key, the T1040 encounter. So you provide the right service to the right individuals. It creates an encounter in your EMR. That's what then ties to the PPS rate that Dr. Brashears mentioned. It is a daily rate. So if someone comes in and receives a assessment with your access team, then they go on and they're doing some treatment planning, you only get the rate one time. It is a daily rate. So whether you get one service, multiple services in the day, you get that same rate. But it is a really nice rate. And so every time they're seen by us and they do all the right things, it should generate the T1040 encounter. And so we started with analyzing all of your service data. So anything that was CCBHC eligible, provided internally or externally. We then filtered it down to those who have a CCBHC diagnosis, eligible diagnosis in auto. If they had services that were prior to auto, which was June 1st, we did look at your avatar data to see if that individual, because we are looking at the full fiscal year across the two EMRs, if there was evidence of a CCBHC diagnosis. If there was, we flagged them. So what we found of CCBHC eligible services for CCBHC individuals with a diagnosis, about 68% of the encounters had that daily T1040. So it's just a matter of why not more? Why not all? So we dug in, we're able to look at this on a monthly basis. And so it's pretty consistent. Around that 68%, we are able to look at it by program. So some stood out as like, okay, that makes sense. It's an external program. I wouldn't expect the T1040 to be high. There are times where someone might get individual therapy from Bethany Christian Services, but hey, they just happen to have a med review by your team here. They did generate a T1040, but the rate's going to be very, very low. So then there's programs like your new DCOs that I was just surprised was kind of on the lower side. One was 31%, one was 70%, 78%. And so again, that 68% are also like, there's a reason why it's good, but these ones are like the people that have the diagnosis and who are getting them by your internal team or the DCO. So there's a lot of individuals that are also served by providers, all your other mental health providers, that they're not DCOs. So really, we should not be generating the T1040 encounter for them. So it kind of evens out a little bit. And just to share some of the good news on, like Dr. Brashears mentioned, this information is being acted upon. So when I ran the numbers this morning, I could see that there's been about 10 to 14% increase in the T1040 account generation for your DCOs, which is great.
Yes.
Okay. So our first recommendation, putting all the pieces together and really trying to understand how auto does what it does. So the first piece is that we're recommending is that individuals are enrolled into the CCBHC policy. So can you go up just a little bit, Amanda? So I just have a little image of what this looks like. Oh, just a little bit more. So if someone has Medicaid or they have commercial insurance, this would be identified as the insurance policy. For CCBHC eligible individuals, it's my understanding that there is this dummy insurance policy created, CCBHC demonstration. When that happens, then auto knows that, oh, this person is a CCBHC individual and creates the T1040 if they're doing the right CPT code on that day. And they have a diagnosis that also aligns. Right. So if you have it all set up, it really should be automatic. So this is where I believe you alluded to that this is being acted upon. So I did see the email come through this morning. All 247 individuals were reviewed, and they're being investigated as to should they be enrolled in the policy plan. If yes, do it. If not, there's a reason why. Okay?
Yeah, and one of the things is you're eligible if you, like, say you're an IDD adult and you have a secondary mental health diagnosis, you're technically eligible. But I've put in the principle that unless we're treating that mental health condition or it's part of the goals and objective in the plan, then we shouldn't give ourselves the benefit, believe it or not, that extra revenue, because we're actually not addressing or treating the mental illness. And what I'm afraid of is that CCBACs throughout the state, they're just generating this for developmentally disabled people without actually treating them, or committed fraud to me, or double dipping. If you have somebody that's IDD adult that got a diagnosis in 1905 of an anxiety disorder and it's showing up, and we're going, oh, goody, we can get $400 more each encounter, but we're not going to treat it, I'm not doing it. So we're going through, and we found out today in our meeting that a lot of our missing people that are not enrolled are exactly IDD adult. And we're going back in now and saying, should we be treating this condition or not? Working with their families or guardians with the consumer. And if the answer is yes, then we'll get them enrolled and do that. If it's not an issue of concern or a focus of treatment, I am electing that we don't take the financial benefit because we're not treating the condition. And I'm worried about a future audit that comes out and says, so you have all these IDD adult folks that you got all this money for, but you did no mental health treatment. I'm worried about that, so I'm stopping that. Now, it helps us, we now have additional resources to do the treatment. So your initial report plus stuff that our COO and the team already had going has led us to a perfect place of evaluation and then setting up our own ethical guidelines, because if not, we could be generating revenue and not providing any care.
Is there a window for retro enrollment?
I
Is there like a?
how far can we go back?
You can go or anything like that?
Really good question.
Right.
Okay.
I
Right.
think we're going back to June 1 because of the auto implementation.
Yeah.
So we're working on last fiscal year, because this is sort of that dummy program, that Brittany was referencing, that we would put the restrictions on that. So really it's the timeline for getting encounters submitted.
Okay.
So that's what we have to follow. That's our December 29th, I think, is
Yeah.
the last day we can submit
To the state.
for
Yeah.
FY fiscal year 2021.
And that might help us in some of the revenue side
Yep.
that we had issues with.
Yeah.
Now, I take it you have uncovered where we have foregone the 1040 billing because we have not properly enrolled people in the STEMO program, the policy.
Yep, and so those 247 were identified, as well as every service that was provided to those individuals and passed
So a
on.
lot of people,
Yeah.
Mhm,
a lot of service.
a lot of service, yeah. Mhm.
But we still provide services to them under conventional Medicaid?
Correct.
Okay,
Yes.
so if we're able to retroactively enroll them, that should transfer over some of those Medicaid charges and
Mhm.
reduce our burden on the Medicaid side.
Yeah, it moves Medicaid expenditures from one Medicaid budget to another and brings down additional
Mhm.
revenue. And that's why everybody and their brother was like, CCBHC, because of that reality. But I think they're on their, actually technically the third manual, but it's more like 4.5 because they've had like,
Multiple.
we keep changing the
Mhm.
rules. Well, not we, the state. So it's been hard to manage.
Mhm, yes. So that, I think, summarizes the first recommendation. Like you said, it's already being reviewed, and so
Mhm.
that's appreciated. So our next one, it's kind of a simple one. It sounds, at least on paper. So we were able to identify that CCBHC services were provided, but the documentation was not completed. So you have the wait in auto, you have scheduled appointments, someone comes to your front desk, you say that they were here, that appointment was kept. There's either a partially complete document or no document even started. And so we're able to identify individuals that you did the work. So let's give ourselves credit for it. Let's finish that documentation. So I'm sure it's more than just that simple, but obviously encourage that moving forward. And we do see it's pretty minimal when you're looking at the earlier months in the fiscal year, and it's going to be a bit higher. So I know I have a couple of charts that might look a little bit scary that we look at. It's normal that there's going to be some documentation unsigned in the more recent months. But perhaps you have some internal standards on, okay, within 48 hours, it must be signed, completed, and you could get at who's outside of that compliance.
Directors are all working on unsigned documents. What was helpful is that we could pinpoint without a lot of people looking where it is, specifically who didn't sign what. So it's making the task a lot easier. And now we're able to replicate that and see that every month. Because if you don't sign it, it doesn't process through. What do they say? No ticky, no laundry, no money. So you have to go through the whole process with it. And so this helped us identify. And the director of the clinical teams are all over it right now. They're like, we're looking at why wasn't it signed? Sometimes it's a glitch in the system or timing. So I know that that's being worked on, but this was helpful for us to see that. And those graphs are scary, so you don't have to show.
A couple of pages.
They're all electronic signature.
You're right.
You're not going through it.
That's right.
Yeah.
Yeah.
I mean,
it's not, yeah.
When I look at the numbers, like with our focus being fiscal year 25, I see less than 100 unsigned documents, which is great.
We have thousands of these things.
Are we using an auto pen?
What is that?
I wish.
Yeah.
Yeah, we just sign it in
Mhm.
advance and,
Mhm.
maybe you could highlight maybe one or two more things due
Okay.
to time that you'd like to share with.
Sure. Yeah, so then we'll skip forward to the DCOs, because I think we covered,
Contract providers and
Mhm.
CCBHC. And just to remind the group, they have to be approved by the state. Is a whole process, or we would just say any provider could be one, right?
Mhm.
So this is a robust process that takes a while, which can create delays in capturing the revenue and billing.
Mhm. So
Keep going.
we'll see, so it was shared with me, like your DCO request form, there's a formal form. So even a little bit more, I think it's like the next page.
Yeah, we had a lot of people.
Yes, so this, I just kind of grabbed a screenshot of, this is the formal request for both Samaritas and preferred employment. So the request was the end of March for Samaritas and then the beginning of April for preferred. So as I was analyzing the data, I was surprised that I didn't see any T1040 encounter generation until August. And so I know, what I'm learning as we brought that to leadership is it does take some time to get the DCOs on board one, approved. MDHHS does allow us to retro bill back to the approval date. But there is a decent amount of work, I think, to get them into the system. They need to be documenting in auto. They need to create the documentation. So there's a service activity log is what is called SAL. They need to do the documentation just as they are an internal staff person. They do that, that's what generates the encounter. And so that was something that it was just, again, it stood out as, oh, this is alarming, I'll share it. So there's rationale for some of that. And then what we're doing is, earliest documentation was August when the DCOs were requested in March and April. So we've also been able to look at then anything after August. Okay, we're all set up. We expect them to be generating those T1040s when they're providing the service. And so there were 362 services for Samaritas that we just didn't see the T1040. And it was for individuals who have a CCBHC eligible diagnosis, getting the CCBHC eligible service. So again, with a morning update, one of the programs went from 60 services without a T1040 to 11. The other one went from 300 to 176. So we're seeing progress made. Recovery management with Samaritas went from 67 to 38. And so we're making some progress. I did notice a new program on the child side. Again, it's good to see these DCOs the programs are being created, the services are generated. We just want to make sure they have a T1040 tied to them. So.
And that's good news because it talks about that transition. And then once you identify it, people actively engage to rectifying the issue. And all that is additional revenue that we're missing and allows you to allocate expenditures to those services. And so it allows us to make some adjustments on there. And I know that even before IBH's reporting on this, we were working on it. This adds value. And I like it because it's an outside entity that's working with other CCBHCs, educating us and helping us build the internal controls of it so that we can manage this benefit. And this benefit we're at full risk for. So we need the most up-to-date approaches in managing CCBHC, capturing revenue and managing the expenditures so that we don't put ourselves at risk or a financial loss. And so I had told the board we would put in controls and start to look at this, and it's been a process. And Anna and her teams have been working hard on this because every time we get the definition straight, the state changes. I mean, this is a moving target on a back of a Ferrari, and you're trying to hit the bullseye every month. It's that complicated, but we're getting better at it. Would you like any closing comments, or is that kind of?
Could I ask
Yeah.
a question?
Mhm.
Take Samaritas as the example. They became a DCO. They started serving clients. They sent us billing for the encounters that we presumably would pay, but we didn't have the proper documentation to submit a 1040 reimbursement from the state. So there's a possibility we have spent money, but have a liability for a receivable from the state.
That's a good question.
The 1040 has to be complete, forms submitted to the state, and then sometime later, the state reimburses us for it.
That's a good
So there's a
question. I
lot.
don't know. I don't put people on the spot, but I don't know, like, if we pay out, like if it was to a DCO, a bill
Mhm.
that we haven't got the revenue, like we haven't done that with. Like, I don't know what the reconciliation process for CCBHC DCO services are. Like, I don't know if they can submit a claim without us submitting it and do it. I'll look into that.
Okay, and then the other part of that is Samaritas bills us for an encounter, pick a number, $50.
Mhm.
We submit it to the state for a 1040 rate and we get $90 back. So that's where presumably there's an opportunity for us to have more revenue than our direct expenses to cover some of our overhead.
Mhm.
Correct.
Yes, yeah. And my understanding is these are organizations you'd been working with before you chose to form that DCO relationship. So it's a pretty long journey. So I do believe you were already, those organizations were serving your individuals. You have internal staff that were working closely and trying to build that agreement because they have to basically adhere to all the same criteria that you all have to internally. So training requirements, staffing requirements, there's a lot that goes into it. And so during that time, you have an agreement based on your contracts that, you're going to serve CMHOC clients at this rate. And I don't know if there's rate negotiation or if there's other things that happen once that DCO relationship is formed, but it's a pretty long journey. So with those end of March, April request dates, I think it was like August 1st or so that MDHHS said, yes, we approve of that DCO. So technically you can go back and say like, hey, we can retro back to the
Right. Certain
request
dates.
date, but nothing was set up in auto from my understanding, right? Like you were just kind of like, well, we'll put in the request. We have to wait to hear, and then we get the approval, and then you have internal staff who are now responsible for managing that relationship, ensuring that they're providing the services that they committed to.
Yeah, I don't know how you'd set it up more complicated than that, but the idea with CCBHC is the CCBHC, which we are, has to provide 51% of all the services. And so you can have DCOs, but you can't have them produce most of the services. The whole idea is that you as the entity are doing it directly, and they're allowing contracting out, but it can't be half of your things. So like Network 180 has this delicate balance trying to figure this out because they contract out the majority of their services. And so it's tougher than you think. And Anna's always reminding me, like, remember 51%, and I'm going, okay, how are we doing? So like the reality is that's the other part of this enterprise. Other questions for IBH?
This is really helpful. Appreciate it.
Of course.
Yeah, and both of them started off as interns here at Ottawa CMH many years ago. Under Dr. Luber's, Darren, do you have any closing remarks?
Well, just kudos to the progress you're making, those numbers that were just shared and the progress. I mean, you guys are obviously right on it. So just really appreciate the partnership with us, kind of like examining these things, discussing them with you and your leadership team and the just the quick, effective push that you guys have accomplished. So that's just fantastic. I mean, this is, I think, like extraordinarily important execution time for all of us. So great job with that.
Thanks, Doc.
Be good with that one?
You're welcome to stay if you like, or leave if you need to get out. All right, the rest is pretty
Yeah.
routine, but
Isn't it?
Okay, next up, we have old business with an update in regards to
yes.
federal rates.
As you know, we've been dealing with the specialized residential rate project initiative for over a year. Just to remind everybody the progression, we started off with meeting with providers, understanding the cost of care variables, coming up with a working level of care system for residential services, developing an initial rate calculator, meeting with all of the providers to say, based on what you've told us and our rate calculator, here's where we think we need to increase the rates, right? And then we had a November surprise of a deficit that we had to kind of address. And then I've been talking with the region about our ability to increase residential rates if we have a projected deficit for the year we're in. And it's created an interesting dialogue that I intend to conclude this week with the region about how do we do that. There's no doubt that we need to significantly increase our specialized residential rates. There's no doubt, based on the testimony that we've heard many times, we need to do this as soon as possible. So I'm in this pattern of how do you intentionally increase your budget to create a deficit. Technically, this year, we submitted a spending plan based on this year's projected revenue and expenditures to the region that's balanced. So if you would ask the region right now, they'd be like, what current deficit? That was last year. This year, you submitted a plan that says you'll cover any potential deficit up to this amount. And so I'm in this kind of standoff of like, do I have a deficit? Well, I have a budget plan that's supposed to address a deficit, right? It's my belief we have to move on the specialized residential rate increases. I'm going, as you know, this board approved the new rate structure last year and we carried it through. We've already approved the new rate structure and level care system for new people. So what we're talking about is adjusting rates to the remaining folks. As Board Member Byrd said last time, maybe it'd be easier if all of our providers just discharge everybody and then readmit them, right? So to prevent that happening, what I'm going to do is this. In our fiscal year budget right now, we had budgeted as a CMH, as a county, a 3% to 4%. I'm going to get the exact number, around 3% increase for CMH staff. It also includes benefits. I'm going to use my authority and increase the specialized residential rate as soon as possible by 3%, the same amount of the staff increases that we approved this year. We've already got that. And then I'm going to work with the region over the next 15, 16 days, how to solve the remaining of the increases that we need to do to stabilize our network. And work with the region, because Lee and I met with them today. Great news. They have a new rate calculator. We've been instrumental in helping them. They're going around to other CMHs, and we want to apply it region-wide. I cannot wait several months for that project to stop, to finish. So what I'm going to do is initially, effective January 1st, increase all specialized residential rates by 3%, and then look at the difference and figure out by February 1st what needs to happen. Now, we had, I think it was you, Sylvia, that said, hey, listen, you have the authority to increase the rates based on the rate structure. However, if it's over like $500,000, at least come back and tell us. I think that this 3% annualized is around $700,000. It's close. I will have the exact amount by our next meeting. But if I don't move and at least match with our residential providers what we're doing with staff at the county level, I think we're going to be in real jeopardy of a system collapsing. Not to mention, to be honest with you, the breach of trust I have gained with residential providers over the last year. So I know I can't move the whole way at once. Some cases, it's 25% the increase that's needed. That's how far behind we are, the rest of the region and the cost of care. But I got to have movement, and I got to resolve this, and got to have movement now, or we're going to have a bigger problem. And I'm going to be honest with you. I can't justify a rate increase for CMH staff without doing a corresponding rate increase to a series of providers that have gone without for, in some cases, a decade. So this does mean we'll have to increase our expenditure side. We'll figure out what that is and let the region know about this. But no, it's not even close to the full way we need to go. If I don't move in any direction, we're going to have some real problems with several of our network. The region has been 100% supportive with the rate calculator, addressing this issue for specialized residential. We're just in a pattern which is taking an amount of time that we can't wait to start the movement in addressing this. So questions on what I'm saying?
So if that is about, 3%, it sounds like overall we're looking at about $5.6 million.
It's our estimates is that the total increase about 3.8, and then there's some exceptions.
Beyond the 700 or including?
Including. Now, it depends though, like if there are a massive level of care changes, right?
Mm-hmm.
But 3.8 is really what we're looking at as an initial. I can't do the 3.8 at the moment.
Yeah.
Right? So I got to have some movement to address that. And I got commitments by the regional entity to meet with the state with the data that we have to try to get more revenue. Because we have to move on this and we can't wait till the spring. We can't wait till it's too late at that point. So I'm just letting you know that I'm going to start that process now and then work with the region on how to deal with a planned increase in Medicaid expenditures throughout the region. If there are other regional partners that are giving back money, I think that money needs to come to us. Okay. But any questions on you see how I'm pairing the 3% with the staff increases, why I'm doing them parallel? The gap continues if you don't.
And now, Michael,
Yep.
I encourage you to continue on the path that you've opened the door to, but I don't believe it's enough. If I'm drowning and you throw me 1/4 of a life preserver, doesn't do me much good.
That's right.
And whatever the metaphor we want to use, we're not giving people half a loaf of bread that they need to keep from starving. We're giving them one slice of bread.
Right.
Well, that keeps them alive one more day.
Right.
What they need is that whole loaf of bread.
Yes.
The other part of it is, if you believe you have the authority to do 3%, I would say you've got the authority to do 100% of what you need to do to have equity in the system. Now, we have an imbalance, and I was wholly in favor of providing an increase to provider A, who was going to go bankrupt and shut the doors and give us 40 consumers to find another placement for.
Yeah.
And if they are entitled to X dollars,
Right.
how can we justify a provider over here that is also underwater saying, well, we're not going to
That's
give
right.
you X dollars, we'll give you 10% of that.
That's right. I'm talking about a 3% around, maybe more, at January 1st, right? And then evaluating what happens in February, right? I have to work with the region to get them to understand that this has to be part of our expenditure plan. That's going to increase our expenditure budget beyond the revenue they're giving us. And that happens every year in the region. People submit a plan and they go, yeah, we're gonna break even. And then next thing you know, you're 5 million, 18 million, whatever in debt. Well, two of us anyways, because we're trying to modify that. But the difference here is I want to have an opportunity to talk to the region about when I'm planfully doing it and joining sides with them to understand that. So that the region doesn't say, you don't have the ability to raise rates if you're gonna increase a deficit beyond your revenue, which will open up another can of worms with discussion about how we're managing this. I guess what I'm saying, I need to do something immediate and keep the full court press on. Like, I'm not talking like months from now, like the very next day, keep working on the rest of it. Because if I don't have any movement right now, it's not a half-life preserver for some of them, it's none at all.
Okay, but let's talk strategy now. The dilemma
right.
is that the course that you're talking about taking may send the wrong signal. Mary, are you listening? I hope
Yeah,
the
no.
region is monitoring our meeting. You give a 3% increase and the region's gonna say, well, that's it, no more. You've done your increase. And presumably a 3% increase will create a deficit beyond what has been budgeted.
Yeah, not much,
Small,
but yeah.
But it's the principle. You've crossed the red line.
Mhm.
Go for the whole deficit. Go for the $5 million
Yeah.
solution to fix the problem that we know exists, because you may not be able to get a second bite at the apple.
That is a correct strategy. The thing I'm hoping to get is agreement that I can use the Lakeshore Regional's rate calculator.
Yeah.
Because if I can use that, the region themselves have said this percentage is needed and implemented immediately. I just need a little time.
Compared the LRE.
Yeah.
We've compared the LRE rate calculator to is better than nothing. I get completely what you're saying, but I think we work really hard on the relationships with our providers, and like they're like giving them a little bit will hopefully show like we're still fighting for them.
Yeah, and I need agreed upon numbers from the region. Because if not, they just attack my rate calculator. Now, I may have the authority anyways as a CMH that's delegated this function to say, too bad, right?
Sylvia, maybe you can speak to this. It's taken me now nearly a year to understand this to the level, the granular level that has me fully behind it. Okay. The public perception always around our
Right.
budgeting is so far off. The calls I get are from consumers, they're from constituents that say, if you're running a deficit, why are you spending more money?
That's right.
Right? And so, and that's not.
I get the question every day.
That's not a 10-minute answer.
But what's the alternative?
I understand.
You don't spend the money
I mean,
and you go
that-
under.
That's our responsibility.
Yeah.
Right? That's our responsibility to answer those questions. But I think the Board of Commissioners needs to know this as well as, as well as the people in our community.
Yeah, the
You
Board
know.
of Commissioners, she had to educate,
I know.
ask me, Dr. Brashears, you have an estimated deficit last year. How are you solving it? I'm like,
Right.
what do you mean? We have the ISF, we have all these things.
Right.
And it takes a village to kind of people can't get behind or can't wrap their arms around easily.
Your mindset.
You got $1, you want to spend $1.50.
Right.
How do you do that? And how do you pay the $1.50? And I'm like, we don't even know our revenue projections until the end of the year, like finalized.
Well, it's so complex, and beyond being complex, it's not just data, it's people.
Right.
And so you start closing homes, you literally have our most vulnerable people with no place to go.
Right.
So whose house are they going
People
to?
don't think about that.
No,
They
no.
think about what are we spending now and why are we spending it,
Right,
right? They
right.
don't understand what it would cost to send these folks out of county. They don't understand what it costs to send them back home.
Right.
And the risks that are entailed in that. Those are the stories that I think people need to at least have a better understanding of.
Yeah, and my intention in bringing this up here and not going for the full Monty immediately is to give myself a period of time to work with the region to see if they can understand. They are aware that our rates are way below, not way below, but below every other partner. We had testimony from providers saying, gee, I could kick out every Ottawa person and fill them with Allegan people and I'd be fine.
And that was very powerful testimony
Mhm.
on all levels.
And I think
Thank
that's
you.
really important when you're talking to the LRE is that they are paying these rates for the other members of the LRE.
Yeah, all we want is the same rate as everybody else is getting.
Sure. Yeah, and they're like, well, you get to manage it, Ottawa, do something less somewhere else. Right? So I'm letting you know, I'm not going to wait to start the process of dealing with this issue, but I am going to buy a week or two to talk with the region to say, how do I get the rest of the way?
I think a week or two is fine, but,
Yeah.
but you're right. We got to get to the rest of the way.
Yeah, I
And
got-
Michael,
Don't let us forget after a week.
let me restate the question that you asked before.
Mhm.
You're spending $1 right now and you want to spend it, and you're breaking even. Now you want to spend $1.25 and you're going to lose money and create a deficit.
Right.
The answer is I need $2.50
Yes.
to meet my cost of my providers and provide the services that my consumers are entitled to. And you know, how you get to that number, do you do it in little steps, or do you go back to the region and say,
That's
here's
piece.
the problem, I'm only gonna be able to put this much in today because of the change in my pocket,
Right.
but you've got to help me come up with the
That's
rest of the
right.
money.
Right, and I just want the chance to do it, but I'm just allowing this group to know and the public to know, I'm not gonna wait around for months more trying to figure this out. We have to start moving now. And I want to do in this region that probably hasn't happened in a long time, to have a honorable, respectful conversation with the LRE and their board of the impact of us making decisions on the rest of the partners. Because there are decisions that are made that create deficits in our region with no concern of what that does to Allegan, West Michigan, Muskegon, Network Way. People just do it. And I'm trying to do it in a way that says, you know what, I'm aware of this. I'm also aware of our cost, and I've shown you that. I'm also aware of a process I've used, which no one has been transparent more than Ottawa CMH on the residential system on how we're doing this. And I can bet the farm on that. And I've done that, and you're already moving in that direction. So if you're going to tell me I can't intentionally increase the deficit because of the impact on the partners, we need a quick conversation about how people have been doing that for 15 years. And what's my ability to manage if I can't do that? I also got staff that are worried sick that the more we go in deficit, that sooner or later they're going to say, Brashears, I have this direct question. Are you just going to like eliminate one of the teams or two of the teams? Because what do you have control over? The directly operated. We are controlling directly operated money the best we can, not filling positions, reducing costs. So I appreciate this discussion because I knew I might get some feedback, go all the way. I just need a time period to really take a pause to say, dear region, here's all our evidence. Let's have this discussion for real. Technically, I don't have a deficit because we submitted a spending plan, which, by the way, solves all the problems of last year's 5% trends not continuing, right? That's already hard. We want to be honest and transparent to our regional partners what we're doing. And I wanted to bring it up here because I want to deal with these rate increases, like now, the certain movement, and then try to get to some resolution in the next week or two with the region on how to proceed. Because I may need this board in the community's advocacy to say, if you're going to say Ottawa County stay in your budget under any circumstance, then we have to have a serious discussion on revenue. Because I think, and I've said this publicly, it's breach of contract to give me less revenue than I need to provide the services you're asking me to do.
And that's why I keep saying, are you talking to our lobbyist? And so I actually think it's time for us to call a meeting with our legislators and bring them in
Okay.
and sit down and explain this to them, because you need some advocates to get the money going to the LRE to Ottawa County.
Yeah.
Bonnie has a question.
Hi, Bonnie.
Hey, Bonnie, do you have something you need to say?
Yes. Can you hear me?
Yes.
Yeah.
Okay, thank you. Has there been any discussion with the providers if this 3% would help them along the way? Or I'm just wondering how that would feel when their need is so much
Yeah,
greater.
well, no one's heard about it till right now, because I decided 20 minutes ago. Okay. Well, actually more
Okay.
20 minutes ago. But the reality is the 3% is almost equivalent to millage payments that we made to some of the providers. Almost, not near, but almost. And so I took away the ability to use millage to stand in the gap. I'm using this 3% idea to stand in the gap immediately when I'm trying to get the rest of the way. So I know I haven't heard. Some providers will be like, fine. Some providers will be like, so I drown slower, right? So I get that.
Yeah.
Now, remember, all new admissions were already at the new rates. And so we're really trying to correct a historical problem and catch up.
Yeah.
Unfortunately, we have to catch up 20% or more in some cases. So no, Vonnie, I have not asked anybody. I know what the answer will be. Thanks, I guess, but
Yeah.
but I have to do something while I resolve this. And I sent out an email to all the providers suggesting I'd have a date like this week I'd get to this. And I prepared them for this, like what I'm up to with this, but I did not include, and I'm temporarily, I'm increasing your rates by X as an initial response, because some of them are like, I did get some response to the email outlining the problem. They're saying, I guess we're not going to get an increase because this is going to take forever. And I don't know, people have been polite not to respond back and say, we don't trust you anymore. They've been polite. They said, we'll work with this, keep us posted, which is admirable of this provider network. But Leah, I don't know if you get, but I mean, that's the tenor. We haven't said haven't heard back like, gee, I see how it works.
Can I answer Bonnie's question? Bonnie, this is not going to solve the problem, but it will make it less worse.
Yes, appreciate that.
Now, I do, I think, Michael, we need to separate what you're needing to do for provider rates and equalizing them around the region is one issue. Forget the region, forget equalization. What do we need to do in Ottawa to preserve our network of services? That's the primary question.
Correct.
And if you can also conform the region to a standardized rate plan, that's great. That's
Right.
Wonderful. That's totally separate from deficit.
Yes.
So don't even bring up deficit. The problem at hand is, how do we preserve our provider network and pay them? Now, what happens if Consumers Energy raises our electric rate by 20%? What do? We say, oh, well, we're not going to pay it.
Well, some people,
No,
yeah.
no.
Well, oh, yeah, if they did that to us.
Yeah.
Yeah, because I was
Yes,
thinking like
no,
in
no,
general,
pay it.
some people can like
You
turn off
have
the
to
heat.
pay
You
it, and then
can't.
you're over budget for electric.
Right. No, don't you know, this is what keeps me up at night.
Yeah.
This is why I get paid to deal with these things. What I'm trying to do is move forward in an environment that is beyond turbulent. This time next year, there could be no regional entity. There could be none of this discussion. We need to move forward now so our provider networks are not left holding the bag if their systems change. I'm just saying, believe me, I'm hearing the message. You might as well go for it. I want a little time to do the analysis of the impact, knowing that we have a rate calculate the region that is similar to ours, that validates what we're saying. And I don't need the rest of the partners to agree. I don't, because if I'm them and I'm already paying higher rates, I'm like, yeah, I don't know, see you next year, right? So I'm just letting you know I'm taking some immediate action, and it's because it's over a certain amount. I thought I'd tell you, right? And then I'm going to look in what we have to do to come to the rest of the way quickly.
We frame it as a beginning step.
Yeah, can't be the only step, but we have to move now, in my opinion. And to me, if we don't have the ability, look, our staff works really hard. They deserve an increase. I get it. But if we don't have the ability to say, we're not going to do that, if it could create a deficit, but we can't do that. To me, I start getting into a real problem where I'm favoring the directly operated system. And as the CEO, I can't do that. I gotta look at the whole system of care. And right now, the county commissioners control what the increase is. I do not. I don't get a vote on it. I don't get a decision. They say it's 3%. It's built in the budget. I have no ability to say, there isn't enough Medicaid. You manage it. By golly, I'm gonna do the same thing on the other side then. But if I'm the region, I kind of go, somebody doesn't have enough money, why are you doing any increases? Why? Because you have to manage the network, both the directly operated and not. And things cost more. And you have handouts on Medicaid eligibility that we're going to go over at the board meeting. I just want you to have in advance. They're going to show you in Ottawa, we've had a perfect storm. We're serving relatively the same percentage of Medicaid people and exact people, and our revenue keeps decreasing significantly on the Medicaid side. Like significantly. And we're the only CMH in the region that's having it to the degree we are. And that's why we get to, I need $2. And to me, the region has to ensure enough Medicaid is provided to meet this need. And I've been collecting data and saying that for a long time.
And that's one of the reasons why I think you need to go higher and talk to like legislators, because
Yeah.
all of these layers are shifting and who knows who's gonna be in charge.
Yeah, what stops me from now, is the system going to be the same? I should know in a week. So what am I talking to legislators about? Because right now they're like PHP restructuring, you're for it, against it. I'm like, whoever takes care of the needs of the people, I'm for.
Nothing yet.
I think we
Yeah, but it should be today at 5 by 5.
Yeah, I think
But then we talk.
I think you need to talk to them about this whole rate structure thing has to change. That's the bottom
You
line.
bet,
No
you bet.
matter what the layers are, that has to change.
Okay. So it's a longer update, but it's one that needed to happen today because I sent out information last week. And if people are paying attention to their email, they could be going, what's going on? So I just send it out. So that's why I wanted to explain myself.
Okay. So let's move on to number 7, new business. And we have the certified community
Yes.
behavioral health.
This is quick.
website.
I'm going to be putting a permanent category called certified CCBHC oversight. And we may have issues every month. We may not, on the various ways that we're mitigating, controlling, and managing that program. So that's just there to let you know in the future, if we have items to report that, I want a separate category. Now, we manage all the funding sources here at CMH. We could have a separate one for each one. But CCBHC is under so much scrutiny in terms of how you manage it. I thought it was important to every month have an update on how that's going. We have it in our regular financials, but if we introduce a new tool to manage it or this, that, you'll see it there. So this is just a placeholder to say in the future, I'd like to have this as a permanent new business item.
So then next up, we have the December 2025 new service contracts.
Yes, I'm gonna let Bill take it.
The good news is we only have 2 this month, so it's pretty quick.
This-
The first one is Sunrise Manor, which is an adult foster care home in Belding. That we have an individual that's living out that way. And we're getting a contract together with them for the adult foster care home part of it. And case management and the psychiatric and all that good stuff will be covered by Ionia CMH, which is called Right Door now, through their CCBHC.
Okay.
So that's the first one. And then the second one we have, there's a new psychiatric inpatient facility in Kalamazoo. That's part of the Medical Behavioral Hospitals of Michigan. And that's what that one's called. And it's a new, it just opened up. They just got their Medicaid number not too long ago. We had a person in there that was in there for quite some time with Medicare, and his Medicare days ran out. So they switched over to Medicaid. And that's why this is backdated to November 4. So we found out after the fact that he became ours because the Medicaid was all expired. So we're working on a contract. So hopefully next month I'll be bringing like a formal contract, but because we don't have the contract set up, we're doing the single case agreement. This is a single case agreement.
So this is a specific behavioral health hospital.
Yeah, so this is, so it's not like KPH, like.
It's not like
no, this is like a new psychiatric hospital,
Okay.
like, Pine Rest Forest,
Gotcha.
type thing down in Kansas.
Okay.
Yeah, it's run through the Indiana. They got like 7 hospitals down there.
Yeah.
So
Okay.
they have a location in Missouri.
Gotcha.
Okay, do we have any other questions on those items at all? No. Okay, then we need a motion to approve the December 2025 new service contracts as presented and forward to the full board with a recommendation for approval.
So support.
All in favor, say aye.
Aye.
No. Okay, and the next up, we have the fiscal year 2026 November financial statement. And we have a suggested motion, which right now it says to approve the fiscal year 2026 November financial statement as presented and forward to the full board with a recommendation for approval. And I'm actually going to recommend that we change that to, instead of to approve, to receive. So that just then indicates that we're taking it in. So, but we'll wait on the motion until after we've approved. So we have Nicholas, Saul, and Mike.
Would you like a motion before discussion?
Sure.
Okay.
Yep.
I'll move we recommend the financial report to the full board.
And I'll support.
Alrighty, so we're looking at 2026 now. I know last month we were still looking at 25. We will have a finalized 25 report once that's all closed, but we wanted to move into 2026. So the data that you're looking at on the first page is for the mental health fund, and this is for services billed and revenue received through November 30, 2025. Just doing a quick overview. So Medicaid, HMP, or Healthy Michigan and autism, those numbers are all revenues that have been received through November. We do not expect any other revenues for those three categories. As you can see, the Medicaid and HMP pretty much zero each other out with the shortfall and then the overage. And we're actually about $500,000 over revenue budgeted for autism that we've received so far. So large increase there. For grants, our October revenues are starting to trickle in now. It's showing a 0 on here because as of November 30, we had received payment for our October grants at that point, but they are starting to trickle in. Actually, we received some today. The county contribution is showing as a 0 at this point. This is entered quarterly by Fillmore, so that'll be posted after December. Other revenue, this is our third-party billing. We have delays in our third-party billing, so we don't actually submit the third-party billing until a month after the date of service, and then it usually takes a month or more to receive payment in. So that's why this is also showing as a less than expected or under budget number. Any questions on the revenue side for the mental health fund? Okay, expenses, payroll, we are still underspent, which is expected with our current vacancy savings and frozen positions that we have at CMH. For client care, as of November 30, we're about $400,000 over our 1/12 budget. For contracted services, this is showing over budget. This is based on, we had one annual final payment for NetSmart Avatar, which is our former EMR system. We had to pay them annual or the full upfront to get to our end of our contract. And then we had some one-time payments for the year. So our quarterly match to the LRE and our annual dues for the Community Mental Health Association. That's why that one's showing a little bit over as well. Any questions on the mental health expenses?
No.
Okay. We'll jump to the back page. I made it a little bit bigger this month, so we have it split on 2 different pages. Looking at the millage and grants revenues. Once again, grants October revenues are starting to trickle in now for our grant payments. We had not received any as of the printing date of this. And other revenue, the main thing that's in this is interest received. So that is entered by Fillmore. Looks like we got about $14 of interest so far, so doing great there.
Thank the treasurer for that.
Yeah, so. And then property taxes, I believe they're due later. So we will start seeing large amounts of that. I know I got mine in the mail, so. Yeah. Jumping down to expenses, the only category that's showing over right now is the MIA treatment, and this is in relation to our 2026 interagency transfer with the state of Michigan. That's also a one-time payment. So just showing a little bit skewed at this point for being over budget. But other than that, every other category, I believe in millage is under.
Any other questions?
I do have, a dead horse to bring up one more time. We show revenue for CCBHC, but we don't show expenses for CCBHC. It's all blended in expenses. It would be nice if you could figure out a way to identify the actual expenses for CCBHC versus the revenue. I realize there's a lag there, just like there is with a number of the other categories, but at some point in time, at least at year end for last year, it'd be nice to know what happened last year with CCBHC. Did it cost us money in expenses over what we got in revenue?
Sure.
Or was there a surplus that inured to the benefit of the agency? And a lot of that gets into your allocations. So I don't know how would you like to make it net zero? Yeah.
Right.
Sure.
We're still figuring that out. I'm smiling because we just had this conversation.
Yeah.
Like, how do we, because a lot of it is intertwined with our
Mhm.
existing network. If we were a freestanding CCBHC and that's all we did, this would be easy.
Yeah.
So a lot of times it's allocating expenditures after the fact.
Mhm.
Once you know how many encounters actually were met and who you had to do them. For DCOs, it's pretty easy. You're paying them fee for service.
Yeah.
Here, it's like, oh crap, we didn't meet how many of these things that we were gonna do, so what can we do with these expenditures? But we are looking at models to do that.
And,
Myra's just asking me, but we were just talking about this week, like, how do we separate them out?
and you won't know what your bonus plan is with the state until when? April, May?
Well, the quality bonus, they do a little differently, but like if, the biggest issue is all last year, we're trying to figure out what our rate was gonna be, our PPS1 rate. It kept changing. We had to keep submitting information. We were thinking as high as $800 extra down, now we're down to $434 extra, and we budgeted for 502, revenue. So because that's been a moving target, it's been hard to comply with the very simple request of, can you let me know what CCBHC expenditures are in a given month? It's been tough because the target's been moving and how we allocate it keeps changing. But our goal is to have such report as quick as we can. It's not a dead horse. It's just a horse that's never been raced yet.
Yeah.
Not even out of the starting gate yet.
Okay, so I think we need to vote on that motion yet to be forwarding this to the full board with a recommendation for approval. So all in favor, say aye.
Aye.
All opposed, no. Okay, so we're good on that. And I think that brings us to public comment. So anyone who'd like to make a public comment? Go ahead, you've got 3 minutes.
I'd like to open, Krista Mason, my name is Hope. I'd like to open by saying thank you. I have some understanding and appreciation of the very difficult situation we're all in. And I appreciate the robust dialogue around this. And I think I understand the strategy. And a 3% increase is less than the amount of money it will cost me to give my staff 3% increase, which I've approved. Because most of them are living at the Alice or below, and they're making between $18 and $20 an hour. So I appreciate this, and we're hopeful that things will move forward with the region, of course. And I'd like to give one other update on a different subject. I spent Monday and Tuesday in Washington, DC last week. And you'll recall HCBS was the federal rulemaking in 2014, designed to make sure that people aren't living in institutional-like settings. We had several, 5 of us had the opportunity to meet with the Deputy General Counsel of CMS, the Deputy Administrator of CMS, and the counselor for the Secretary candidate, and also the administrator of the Administration for Community Living. So these are all the folks that are the big decision makers around HCBS. What we wanted to communicate with them, and I'll share it differently here than I did in front of them. We, speaking of many providers across the state, have the dynamic where federal rulemaking has been then passed down to the states to implement, right? And perhaps well-intended, I'll say that it is, but there's finger pointing happening. The state's saying, oh, we have to put these heavy restrictions on you because CMS said we had to. CMS saying, oh, we didn't say that. The states are implementing it that way. Regardless of the reality of that, it's yet another really heavy burden for providers. And more importantly, it's jeopardizing safety for the people that we serve. So my aim in sitting in front of this group of people is to say, is there opportunity in this administration to roll back, even remove restrictions that are not creating the desired intent of helping people? They're actually jeopardizing the probability that they can continue living in the setting where they are. So I was honored by the opportunity. We'll see if it avails anything at all, but you got to try, right?
That's right.
Appreciate that.
Yeah, thank you. All right, any other public comments today? Being none? Okay. Oh, sorry, thank you. You have to unmute Rosalie. Rosalie, can you unmute?
I hope, did I do it?
Yep.
Okay, so back to self-direction. Each month, the FMS is supposed to send the participant their Medicaid allocation report, which is their budget report.
Correct.
And the supports coordinator is supposed to be involved to help monitor the monthly budget if there's over or under. And it is allowed to like switch if you need more respite, you know, do a little IPOS amendment to be flexible to meet the needs. And maybe that's not happening, but there is a lot of things out of our control that should be red flags. If they're underutilizing, it means the service is not being delivered. And a lot of it is the direct care worker crises. It takes an enormous amount of time to recruit, do the paperwork, to onboard a person, the training, and it's a good 10 hours for that part. And it's the parent who's usually the volunteer to be coordinating the arrangement. We're unpaid. We do it out of love. We don't have an HR department. We don't have other people besides ourselves advocating for what our loved ones need to avoid placement. And I'm glad to hear the numbers, what was like 158 self-D people, and there's what, 200 in specialized residential?
Right.
But that shouldn't, we're not really competing with each other, but
No.
we're just as important as specialized residential providers. We're providers also. We need that 3% for Earned Sick Time Act.
Mhm.
And yeah, we're all competing for the same workers. The turnover is enormous. You're lucky you can get someone to show up for an interview and pass a background check. It's very time consuming, and retention, that's very important. We're allowed to do a bonus, fortunately, but it's getting harder and harder to find people to work with high intensity needs people. And the day programs, they aren't very receptive to high needs people. The social rec, yeah, you can go with the CLS staff, but then again, if your person is behavioral, they kind of don't want to accommodate you. Same with overnight respite. If your person doesn't sleep all night, they don't want to accommodate that. Parents are getting calls, come pick up your kiddo. And I can understand that's disruptive, but if a parent has to do it and does it, why can't these paid providers do it also? It's like we need to raise the bar because the intensity and severity is only increasing, and there's less and less places receptive to high needs people. And I want to touch on the youth. What's happening with like the psychiatric residential treatment facilities in the state, the shortage of beds, their needs are going unmet and ending up in juvenile justice or living in crises. That, yeah, I could just go on and on about the needs, and I understand the funding is short, but there's a lot of work to be done. And I also, because we had a parent group meeting, where are we at on that for self-direction? In the consumer advisory panel or whatever that's gonna be, there was supposed to be a parent guardian group created. What's happening with all that?
Rosalie, I hate to say it, but we're way over. So,
Oh, okay, 3 minutes, sorry.
yeah,
Thank
no
you.
problem. It's okay. All right. Do you have anybody else? Their hand raised. Okay. All right. So with that, we will call this meeting adjourned.
Thank you.